Hello everyone, my name is Nada Salman. I'm a PhD student at the University of Paris-Saclay in France. Today I'll be presenting my paper titled Adaptive Weight Compensation in Assistive Upper Limb Exoskeletons with a focus on EMG analysis. So to introduce the subject, we first focus on the main part about improving human-robot interaction in assistive upper limb exoskeleton, which is making the robot or the exoskeleton more compliant with the user's intended motions. So to first do that, we first need to detect these intentions by having the right sensors, which are force or electromyography or EMG, and then apply the suitable interaction controllers like impedance or admittance. And in this work, we focus on a very specific aspect, which is detecting when users carry or pick up objects, and how can we help them compensate for the weight of this object, and we test that on a 1 degree of freedom, which is the elbow. Before we go further, to introduce EMG, it is or surface EMG specifically, it is a non-invasive technique where we can measure the electrical activity of muscles by placing electrodes on the skin. As you can see in this plot, an example of EMG signals. The gray signal is raw EMG data, which obviously needs filtering. To get a more clear interpretation of the data, we also need to perform normalization, trying to compare between users and sessions. And additionally, we do feature extraction, which is converting the raw signals into more meaningful data by calculating statistical features like the root mean square error, for example. EMG is very important because it gives us insight into muscle activity, into fatigue for users, into the stability of the muscle contraction. This is why it's widely used in assistive and rehabilitation applications. So let's assume now we have a user or patient wearing an exoskeleton, and we have an admittance controller on the elbow joint level. We have a force sensor here on the wrist level that is working well with an admittance controller implemented. An important aspect we need to focus on is the compensation for the weight of the arm. Why? Because this is the point why users are wearing upper limb exoskeletons, is that they usually struggle with even carrying the weight of their own arm. So we need to help them alleviate this workload. And additionally, because we have a force sensor on the wrist level that is measuring this flexion extension motions, we don't want to confuse the weight of the arm on the sensor as an intention to move down, for example, which is how do we get reliable data. Generally, compensating for the weight of the arm can be done by having mechanisms like springs that will pull up the weight, or by having additional motor torque. The problem now starts when a user wants to carry up additional objects, let's say a glass of water or an object that might be slightly heavier than that. How can we help them carry that object? We first need to detect that an object has been carried. Because again, we are trying to make the process automatic and smooth for users. So we're trying to answer, can we detect a measurable difference in EMG signals when a user carries an object? And if so, can we help them reduce the muscle strain by adding this motor torque or compensation for the weight? First of all, let's try to talk more about the system we use, or the exoskeleton, which was based on the Agio Exo Pro wearable exoskeleton. Now, this device is not an assistive or a medical device. It was only used as an initial approach to test the idea. It has 2 passive degrees of freedom for the shoulder and 1 actuated degree of freedom for the elbow flexion extension. It can be fixed or attached to the user's arm wearing cuffs. And it has a straight bar load cell force sensor on the wrist, and the MyoWare muscle EMG sensors that can be placed on the biceps brachii, because it is anatomically significant to the flexion extension motion. For the experimental protocol that we did to test or answer these questions, we tested on 5 healthy users aged between 24 and 30. They were seated comfortably on a chair. They were asked to wear the exoskeleton that already had admittance control implemented on it, and the weight of their arm was already compensated for. They, of course, all signed consent forms and completed a post-experiment questionnaire. Then they were asked to repeat 3 sets of motions of flexion extension. Each one was 4 repetitions. And they were asked to do these repetitions while wearing the exoskeleton with as little effort as possible for us to try and gain insight that would be similar to patients or users with muscle weakness or muscle dystrophy. Now, in phase 1, or in the first set of repetitions, they were not asked to carry any weight. They were just repeating these motions while wearing the exoskeleton. In the second phase, they were handed a 1 kilogram weight or object, but not assisted with it. And in the third phase, they were assisted manually. We added the compensation to try and help them with this additional 1 kilogram weight. After we collected the EMG data, we of course performed or applied the necessary filters and the rectification of EMG signals, and we did the normalization by measuring the maximum volunteer contraction according to the CNIEM standards to compare between all the results. And for the features, we calculated 2 time domain features, which are the sliding window, RMS, and variance, as they are the most commonly used, and as RMS offers more of an insight into the general muscle activity, and variance gives us an insight into the stability of the muscle contraction, which might be related to fatigue, which is an important factor for patients. Now, as you can see in this plot, this is an example of the results we got from one of the users. The first row shows the elbow angles being 100 degrees, being full flexion. The second row is RMS, the third row is variance. The black line or plot shows the sliding window feature of that phase, and the vertical lines, of course, obviously separates between the repetitions. Now, the red dots are actually the average of that respective feature over this repetition, and we only calculated that to have an estimation and try and compare between the phases. So we can see here that the RMS, for example, increased clearly from phase 2 compared to phase 1, as the maximum increased to 0.42, which was 2.5 times increase compared to phase 1, and then dropped again to a maximum average of 0.23, which is a 45% reduction. And we saw the same values or trend in the variance, as the values changed between 0.8 to 6.3 to 0.5, again dropping in the scale of 10 to the power of -2. Between all phases. So again, phase 2 is when they are carrying this 1 kilogram object by themselves, and in phase 3 when they are assisted in carrying that object. And to show the results for all users, this table, the first one shows the results for the RMS and the second for the variance. R1, R2, R3 represent the repetitions, and the numbers are basically the red dots that we saw, which are the average of that respective feature. And the heat map was normalized for each user. So you can see clearly that for almost all users, the RMS increased in phase 2 and decreased again in phase 3, except for user 2. And for the variance, we also saw an increase in phase 2 and a decrease in phase 3. Now, these results showed us the analysis of only 2 time domain features of EMG, which gives us an insight into the muscle activity and into the stability of the muscle contraction. And going back to the questions we asked at the beginning of the presentation, can we see a difference in EMG? And the answer is yes, we can detect when any object is being picked up or any additional workload is being done by users' muscles using EMG sensors, and this could be very promising, especially for real-time applications when we want to automatically change the behavior of the system to help users adapt for their daily life activities. And that when we increase the weight compensation, we actually help reduce the workload on the user's muscles, which is very important for patients with muscle weakness, as it can increase the durability, reduce fatigue for them. Now, in conclusion, this work showed a representation or an idea for detecting when users carry weights using EMG. It presented a device where we have a well-implemented force controller with also additional input from EMG that can be promising for real-time applications. In practical applications, this has the potential to help patients in real life and to assist them in their daily life activities, like carrying a glass of water, for example, which would highly improve the quality of their life. But again, this was only an initial step of the work, and it needs much more further development. For example, the first point that we want to have for future work is actually apply that in real time, and most importantly, work on the mechanical design, because most of the users reported that they felt, for example, a bit of physical discomfort while wearing the device. So we want to prioritize making it more adaptable to all the sizes for all users. And of course, test that on multiple degrees of freedom, because obviously the elbow is not enough for what we need in our daily life activities, starting by the shoulder level actuation. Thank you.
Thank you. So do we have any questions? Okay, so no questions, but I worked on axles as well, so I would like to ask you a question. So as you know that patients, let's say with brachial plexus injuries or strokes, always have weaker EMG signals. Did you consider that as, will that affect your program?
So yes, in fact, any patients with stroke or the muscle or the disease that I am focused on in my PhD, which is Duchenne muscle dystrophy, they will have lower EMG amplitudes in general, and this is where the role of normalization comes. So if we measure the maximum voluntary contraction for each user, we can still see EMG amplitudes for users. It will just be lower amplitudes, and this is why we need to do proper normalization.
Follow-up, you just mentioned the MEC. How would you measure MEC in these populations?
So what we did, for example, until now, according to the CENIAM standard, each